Good morning, friends. It's lovely to see everybody here, and I'll be introducing to you a session which is very dear to me. And I would rather start the session with a proverb which is probably sum up as to what we do and why we are doing. And it says that necessity is the mother of invention. I'd rather go one step ahead and say that necessity is a mother of progress, and probably it is also a mother of change. When robots were introduced in India, and where there was an epidemic of robots, we needed surgeons to come up, we needed newer surgeons to be groomed to handle these machines. And that's when I suppose where Vattikuti Foundation stepped in, and he decided to grant fellowships to surgeons in India. And they have been granted in fields like uro-oncology, urology, head and neck cancers, gynecology, gynec-oncology, and surgical oncology. Ladies and gentlemen, as of now, when I talk to you, we have completed almost 1,500 days of training of fellows in fellowships, probably 32 fellows, including the one that are presently being trained. But that makes me think, have we done enough? Are there any hits and misses in the fellowships that have been offered in India so far? This is what exactly we are going to discuss in this session. Along with that, we are also going to look at how the inception and the current status of the fellowships, the fellows' perspectives, the mentors' perspective. We're also going to brainstorm and see whether proctoring is a different ball game. And we're also going to look at ideal robotic programs. Joining me in this brainstorm are the following panelists: Dr. Menon, who is the Director Emeritus, Vattikuti Urology Institute, Henry Ford Hospital, Detroit. Then we have Dr. Rajesh Ahlawat, Group Chairman, Medanta Kidney Urology Institute. Dr. S. P. Somashekhar, Chairman, Surgical Oncology, Manipal Vattikuti Institute, Manipal Hospital, Bangalore. Dr. Gagan Gautam, who is also my co-moderator, Director Uro-Oncology and Robotic Surgery, Max Smart Super Specialty Hospital, Saket. Myself, who is a former Vattikuti Fellow and presently in Mumbai, and also Dr. Aravindan, who is a present Vattikuti Fellow from Manipal Hospital, and of course you all. So with this, I welcome you all to be a part of this session where we will be churning up ideas which we can give it to the foundation so that it can bring up better and more stronger versions of Vattikuti Fellows.
It's actually very pleasure to speak on this particular topic. When we started the robotic program with Professor Bandari, we discussed a lot about how we can do a fellowship training. So much of discussion we had. This is something which is very close to my heart and passion. Somebody who does the surgery and leaves this world and goes doesn't achieve anything unless you leave actually what you learned from your mentor and what you improvised yourself and you give it to your fellow who is going to improve and do better. So when you come back and look 10 years later, the same surgery what you taught, your fellow's fellow is doing it so well than you really want to be a fellow of him to learn. That's the beauty of modification. And we all fail if we don't actually train them, and then selflessly we give everything possible. But the problem is the expectation and the needs and what you want to give are totally different. Because the expectation nowadays, the new fellows don't have so much of patience, perseverance, hard work, not the Gurukul environment which we started. So yet you have to fulfill their expectation within the given time. Hardmanship is not possible. Every fellowship that starts, they expect that it ends with 100% pass and success and medal. So, and very little of them are able to leave sacrifice. Surgery is something you have to sacrifice many things: personal life, family life, your own hardmanship, food, water, sleep, and you have to do. Gone are those days. All of you know that the fellowships in any field doesn't say like that. But yet, how did it happen? Especially we need a training when you have a new technology, something which is very well established, everywhere you can learn. When you start a new technology, 1,000 people are looking it through microscope to detect not what good you are doing, what wrong can happen to that. So the ones who are not doing can actually join the bandwagon. So many of us actually take quite considerable time for learning curve, and imagine when a fellow comes, he straight away into the learning curve. That is where a good mentor and teacher learning curve which actually comes into very well. So the fellowship in robotic in India is a platform where an interested person who is already accredited and credited to do that surgery by a different means. Remember, we are not going to teach them how to do this colectomy or prostatectomy. They already learned. We just show them how to do with this new device and master it. reach the same quality of surgery what you have been doing and improve upon beyond that. So how do you face the difficulties, how to tackle them is what you do. That's where the mentor and the fellow who is a beginner actually happens. I would really look at what really laid the platform for robotic. The only robotic program which started was courtesy Professor Bandari. If you look at it, what he did for fellowship program, all the mentors, he identified the right mentor, right institution, but the whole concept of fellowship program selflessly actually started here without any expectation or commercial interest or gain, which is very, very difficult in this world, and that's very essential for any teaching program. So when Professor Bandari discussed with like-minded people across India, he thought, okay, I would look at this point in the fellowship program, data entry, publications, trials, they have to present high level in conference, have educative videos which they can share, online forum where they discuss, and they spearhead a multi-institutional study and they form an online video. I can say that out of this 10 to 11, 9 he succeeded, and it's all available. You can just go on all the website and you can look back. So how did any academic starts? Academics, the foundation and the program. For the want of time, I can't run this particular video for a long time. Can we run this video? Yeah. I would welcome everybody to go and actually hear, can we just start this video please? So I would request that everybody should go and see this particular video which is available there on the web.
In different specialties.
I'll not run it, it's available. This is a fantastic video which I heard about the fellowship program. Can I have the audio?
Younger surgeons and surgical trainees who made up their mind that they would take up their career as robotic surgery. So we started a very successful fellowship program, and many of you, I must thank you from this platform, who really mentored surgeons to the level that they could go and independently run robotic programs. Here are some examples wherein
okay, now this actually is a 11-minute video. I can't run this whole video, but I would request you to go back. The whole cusp of what is a fellowship program is available here. Now what is the current perceptive and inception in India? We have Vattikuti Fellowship in Robotics. We have Indian University Certified Robotic Fellowship Programs which are given by universities and accredited by them. We have local hospital fellowships which are not certified by university but very high quality programs. We also have robotic training now integrated in subspecialty training. Somebody who is coming for a diploma at National Board surgical onco training under me, robotic is integrated with us. Same with MCH urology you're doing, institute where you go, they are integrated. Suppose you go to a TMH to do a surgical oncology, already the colorectal is integrated. So it's in part integrated into fellowship, and there is a dedicated. These are the 4 options currently available in India for any student who want to do fellowship program. Now if you look back the Vattikuti Fellowship, which was the first which laid all the platform, which was a non-profit corporation, the fellowship started in 2016-17, and the objective was that very high trained Indian surgeon who can do independently. Not that once you finish a fellowship, you go and work as an assistant eternally under somebody, you are capable to go out and do independent work, what you do. So the model that was chosen was initially to identify, by that time already the robotics was there for about 6 years, 5 to 6 years, and already a program was established. So champion institutions were there, and initially this started in 8 centers where high volume happened and a fellowship. Suppose a robotic gynae onco fellowship happened, the database was available, how was the high volume happened, or robotic colorectal, surgical onco, GI, Euro. 5 fellowships actually initially started. I put these things in the map which started. It was in New Delhi, the Mumbai, the Bangalore, and these are all the hospitals, the Manipal, Kokilaben, Saket, Medanta, Narayana, which started off. Subsequently, as the things progressed, more fellowship were added to this through Vattikuti Fellowship. The gynec onco, the head and neck, the ENT, and then the TORS program, and then the program started in Hyderabad, Kochi, and Chennai. But in between, what happened is, all the programs didn't take up very well the way, because if you look back the feedback of the fellows, the volume, the way they were comfortable, so more or less finally, this is where the Vattikuti Fellowship actually settled down and it was available. What were its parts? It was very important that unless the volume, academics, number and financial stability is not there, no program can be this one. So they got paid at par or sometimes better than the existing pool of the senior registrar who were there. Not only that, if they actually have a very high quality data entry and work they do, and it is accepted, they also had a huge academic grant to go overseas or within India to present there and convert that into a publication, and this is something which is held. In addition to this, also Vattikuti Fellowship sponsored international travel fellowships to important meets to King George and also to Prostate Symposium in New York. We also know that those who have completed a long robotic but they want to refine more, so then Roswell Park Comprehensive RPCCC program for 6 fellows, very popular. Even most of the fellows who completed actually wanted to go for higher thing. All the details are available at this particular link. You can go and read all the fellowship programs which are there, which is available. But it was very important to know at that moment, MCI, now the National Medical Council didn't recognize them, but at that level it just doesn't matter. You already have a basic degree which is recognized. The peer recognition is more important than any national body. All the peers clearly understood somebody who is trained in this Vattikuti Fellowship, say at this institution, so moto are already high quality surgeon, the community, the institution accepted them and absorbed them into consultant post. So you no longer actually had to have that particular thing. So even though it was not MC recognized, the whole community, the hospital, everybody actually took back. So these are the component of this fellowship, providing access to medical literature, leadership quality, documentation, passing the learning curve under your mentor, every day being there for an year. These fellowships are for 1 year, then innovation, publication, and then they become actually member of all top congress because they themselves have reached that area. And the record keeping, those of you who are a part of robotic fellowship in Vattikuti knows that the database is a very robust system, day-to-day entry, prospective, available easily for any publication. Our institution has used this fellowship database and we have made about 6 to 7 publications which are all authored by our fellows as the first authors or they are a corresponding author. So these were the dedicated thing which actually was built up in the fellowship, like 1-minute video what you learned today, and you have an app and you have a WebEx journal among themselves to do this. Now did it meet the expectation of the fellows? If you see that every meet, we actually discuss with them, did we meet the expectation? Each fellow was under a direct mentorship and the mentor took the full responsibility. If a mentor is not up to mark, there are instances in India where fellowship has been terminated or they have been moved to other places. So most of the participants actually were peer reviewed and then were checked back and they were terminated if they were not doing it, and the student is ready to leave the program if it didn't meet his expectations. Now if you look back, what are the expectations? I analyzed all the fellows who actually, I did a small survey to most of the fellows who completed the fellowship among 30 to 36. What did they expected, did it fulfill? It is so heartening to see they are more successful than their mentor and their teachers. Most of them have gone to international forum, have been invited to do that. Their logbook they have maintained is outstanding. If you see the logbook of the fellows they have maintained, based on which you can audit and do lot of your work. Now in addition to the Vattikuti Fellowship, we know there are university, like in Manipal University there are 2 university certified fellowship, and we are also having HCG Uro-Onco, Gem Hospital has also started, Amruta has started. Even though all of them may not be university accredited, but they are high quality fellowship available. Many of the DNB centers in Euro, Gastro and FNB, Fellowship National Board minimal exam, have integrated robotic into this, and we can just go ahead and do that. So this is how the whole foundation of the fellowship program started, with very good skill going in, and the motto that publish or perish. I have a rule that all my fellows should do at least 3 publications before they leave a fellowship program, otherwise they have not done everything. It is not just about learning cutting and sewing that a barber and somebody else will do. What's the difference between them and us? So what is the success of this fellowship program? Did we establish a right program? Did we put a certification in place? Is it placed? And how are we placed them after completion of program? Just program is over, yeah, I have 3 slides and doesn't go. The beauty of this is, when there was a transition from Vattikuti to Intuitive, it took hard work by Professor Bandari sir to accumulate. All our fellows actually get now a certificate from Intuitive at the completion. We know that this has its standing, and this is one of my previous fellow certification. So it is certified by a body given by an Intuitive. Otherwise, you know that they don't come up very easily to do certification. And what I have done is I have integrated this into my university program. They also finish the program, same curriculum, and they write, and they also get a Manipal University Vice Chancellor degree program with them. So they go with 2 degrees, which is efficient. How it showed is, you should go back and read the blogs written by Gagan's fellows about the training, how we did and how it helped and they placed. The success story is, Most of the fellows today are placed as a robotic surgeon in top hospital in India who completed this. This is one of the fellow who completed the robotic fellow, went there, and the other one who went to Hyderabad, who is absorbed as a robotic, surgeon. The other one is in National Cancer Institution in Nagpur. Most of them have done storming and presented good work in international forum, and they won multiple publications and multiple awards. So this is something which actually looked at the whole placement, and enormous amount of publications have been done by our fellows. So the research, we found an answer, on site they are trained, and it is very important to understand that the needs of each student is not same. All students have different learning needs, abilities and preference, and this is something which I told, the last slide of mine. This is an era where fellows are blessed, when we were not blessed. They don't know the value of this particular program. Wonderful opportunity not to let go waste, once in lifetime. Current generations are blessed, and this is thanks to the thing which saw up and went into program, and this is the current status of the fellowship program in India, which is very, very exciting, and about 36 people are trained every year. Thank you.
Thanks, Gagan and Somashekhar. It's good that you have discussed this. We haven't talked about it, but many of the points would be the same or around the same, and because your specialty is different, mine is different. So my fellows would have a different perspective. So there is no question that we need robotic training, because that's world over. The things that robotics and artificial intelligence, they are taking over, and irrespective of the specialties, irrespective of the area, even medicine, other areas that we work, that there has to be, like Matt Damon from California said, that we all are going to have to adapt to artificial intelligence and robotics. Old hands and new recruits will have to learn new ways to do their jobs, whether in construction, lawyering, retail, finance, warfare, come any area, and we have to relearn everything. What he also, said, he visited about 13 centers in US, and he said that, despite, robotics in many centers in US, he said that candidates are still, young doctors are still learning robotics in shadows. In shadows, what he meant was that, it's not part of the curriculum. It's not, what they do is that they are looking at the, sitting on the console without a patient, trying things. YouTube has become a very popular arm of training, self-training by these boys. And they are trying to incorporate robotics because they know its importance. They are trying to incorporate that in their curriculum at the cost of other things. And that's what he said, that most of the people are learning in shadows. So in how robotic surgery would be different from open surgery as far as a mentor. And in open surgery, a surgeon literally couldn't perform a surgery without an assistant, his hands inside. And this changed altogether with robotics. Here, your assistant is sitting at the console. He is sucking most of the time. At the most, lucky ones are sitting on the second console. And even if they are trying, what you do is most of the time, whenever, don't do that, and they come off and you take over. And they are actually sitting in dugouts many times. So what it brings this, that they are spending very little time actually, they are not able to give that much of a time which we were able to give to them in open surgery. And that's why it's important as a mentor to think about this and change that. Other problems as a mentor are that when you get all kinds of candidates, we have trained them in endourology, we have trained them in laparoscopy, open surgery, 2 brilliant people on record, you select them out of the best, and 2 would not go out as equal surgeons at the end, although you would work similarly hard on both of them. So they have their aptitudes. And at the end, what happens that, you have patients, many of us are still in our own learning curve. And I am there, and there are 3 other junior consultants who are also trying to put themselves in. And it's hard to give my fellow a sufficient time with all of this happening. You have a patient, we are working in private hospitals. We have, their relatives are standing in the lobby downstairs. All of them have heard about the daughter of California syndrome. Their sons and daughters, they are in US. They ask 100 questions, and all of them bring up a lawyer somewhere when they are discussing, who comes with a black coat and says that I'm a lawyer. You work in this environment and you have a fellow sitting with you. The job that you can do in 2 hours takes 3.5, 4 hours. The case, you could do 3 cases in a day. You can do only 2 cases. You are hard pressed between outpatient and OT. That's the perspective of mentor, if you think. So, but at the same time, if you have any system, if you have anything that was designed to train, that's RUPS, Da Vinci robot. Actually, this is in open surgery, even if you have your assistant all the time with you, both of you are not having the same view of surgery at any time. Your assistant has a different view and you have a different view. In robotics, both of them are having the same view. He is sitting on the other console. You can even run the video past the procedure, sit with him and go through everything, which is not possible in open surgery. And most of the time when I was being trained in open surgery, even if I put my head, my senior would say, take your head off, mundi off. My teacher would tell me that, you can't get in, I have to do what I see, especially when you are working in the depth, which is not so in robotic surgery. The second console is really the boon if you want to train them. So system is there to train. Vattikuti Fellowship actually filled in the much required need, and there was an objective selection of the candidates. There was a very objective selection of the centers and mentors, and busiest robotic centers, which is important to teach them. They were exposed to volumes, and there was a added tag of Vattikuti. They have worked hard to make it a household name in India as far as robotics is concerned. So there was a Vattikuti tag attached to the fellowship. And they also gave exposure to Robotic Surgical Council training, meetings, as well as international meetings. So I think these are all hits as far as the fellowship program is concerned. And what would add to the fellowship is the same thing that Somashekhar brought out. That number one, that I don't think that we don't have a curriculum. And we should have a curriculum lined out that, there are multiple curricula available, and we should have a defined curriculum. I'll go to them a little bit so that we can have a curriculum built in. Second is accreditation. He has done it at Manipal. Can we tie up, if we can't do it, tie up with DNB. They'll take away all the controls and everything. Can we tie this fellowship to an open university? Some open university, so which can give accreditation to the certificate that we give. That's another thought. And there has to be an exit evaluation. It's very easy. It's not a writing exam. The fellow must submit 10 to 15 minutes videos of 3 or 4 set, like in urology, nerve dissection, posterior dissection, or anastomosis. Just 10 minutes video would be sufficient to certify and tell, anybody can certify that this fellow has been trained sufficiently. Apart from that, in the exit evaluation, we can even incorporate other things, which I'll come to later on, publications, etc. And it will also enforce, if you have an exit exam of exit evaluation, it will also enforce all mentors to work hard with their candidates. At least, this they have to show at the end. So that will happen. So robotic training, several studies have demonstrated that there is a significant benefit of this methodology if you have a defined curriculum. And surgeons trained by well-structured robotic programs fare better than those who did not. This is a European Association of Urology work chart for RARP for a curriculum. So these are 9 steps. There's level of competency and repetitions that are needed in a year. If somebody has done that, it's sufficient. That is a curriculum for a prostate. Similarly, there is a curriculum which can be designed, which is available for partial nephrectomy. So if you have some of these curricula, we can build in uniformity across all the training centers in here. The second hit, as pointed out by Somashekhar, was it's hugely important lesson that to teach these boys that it's important to collect the database and collect in a progressive, systematic way. And that is what they have learned. Although some of them keep on complaining that, the data entry is tedious and it's not as smooth as it is made out. And it can it be app-based? So these are the questions that they keep on coming back. But come what may, there is no questions that this has been one of the very important aspects of fellowship training. But data handling is missing. Dr. Bhandari was asking me last time that, why is it that, the our fellows from India do not ask for the data from VCQI for analysis. And this is the reason that we don't teach them how to handle the data. This has to be another part. And it has to be built in the curriculum that they have to, even whatever, at least 2 or 3 analysis based on our own data, if nothing else, they should be able to do by the time they end the fellowship. So that's another important thing that I think should be added. So another thing at the end, once the training finishes, everybody is not so lucky. And my bother at the end of the program always is where the boy is going to go, whether they would have a robotic program at that place or not. Not everybody has been lucky, as Somashekhar makes it out to be. So they have been struggling to find place for themselves despite being well trained. And many of us still at the end of the program, they said that they would like to continue. And I don't know whether they are want to continue because they don't have placements, or whether they still feel that there is still lack the training and they want to train more. So, that's another aspect. And that brings the question that, unlike general surgery, where general surgeon boys come, they are all trained in laparoscopy. In urology, most of the boys that come, they don't have ABC of laparoscopy. So, they are absolutely fresh as far as minimally invasive program are concerned, and they take much longer time. We have to train them in laparoscopy as well as robotics during this year. So that's another problem. So another question could be that, should we have a sponsored program for the fellowship? That that a candidate is coming from somewhere where the robot is, and he would go back to a place where he would be able to use his training. Even a boy who trains at my place for a year and goes out to a place where they say they will acquire robot in 6 months, the training is gone. He will have to reinvent everything again. So he should go back to a program where he can use his skills. So in conclusions, it fills in a huge manpower need. It gives platform for training a worthy candidate, a worthy mentor, giving national and international exposure, and teaching the importance of data and its collection. And what would improve the program is a uniformity and a curriculum, an exit objective evaluation and accreditation if possible, and ensuring placements. Thank you very much.
Before I start or proceed with my talk, I would like to just tell you why I am here talking to you about all this. As I mentioned before, I was the first Uro-Oncology Vattikuti Fellow from Mumbai under Dr. T.B. Uraja. Since then, I have been associated with the team, and I have seen fellows who have joined the institute after me, and I have been a part of their mentoring. And now I have been also given an additional role of the VCQI coordinator for India. So my interaction with the fellows have been quite dynamic on both the occasions. Now, as far as I am concerned, what were the hits? As far as my fellowship, what would classify as hits for me? First is, before the fellowship came, the only options we had was either to give a USMLE, go to US, or to get yourself enrolled in a program in UK or in the European programs and get yourself certified as a robotic surgeon. But the Vattikuti Fellowship came as good news for us, and we will be, so the whole idea about getting trained for this new technology was very exciting, so this was the hit for me. It also helped me to join a good high-yield center and expose myself to different variety of cases and gain more and more experience under a good mentor. And finally, it also helped me to being a part of a larger robotic surgeon community. Let's focus on the misses. So what are the misses? As Dr. Ahlawat mentioned, I believe a structured curriculum is absolutely necessary to enhance the existing robotic program. What that means, it includes simulation activity, clinical training, and also not only the clinical, but the non-technical skills. In fact, in EAU 2018, a discussion rose, which the paper has been shared by Dr. Ahlawat again. They discussed the curriculum looking into how to train a fellow as far as partial nephrectomy is concerned on bedside and other curriculum. So this sort of an idea can be incorporated in our present fellowship. In the recent, also in EAU 2019, a similar structured program was been discussed for training in robotic cystectomies. Objective assessment of clinical skill is absolutely essential, particularly when we are talking about patient safety. We want the fellow to be a safe robotic surgeon when he leaves your institute after completing the fellowship. The objective structured assessment of technical skill, that the OSATs, was introduced into 1997, and it has been taken over by a similar program called GOALS, which assesses the laparoscopic skills. A similar program has been introduced for robotic objective structured assessment of clinical skill, which is our OSATs, and there are few papers which are there in the literature to read. So a similar assessment program should be incorporated. And I want to mention here about what Dr. Ahlawat mentioned about uploading your video and getting it peer reviewed by many mentors who can give you insights about how to go about doing it much better. I also believe that we need to have an interactive robotic online forum where the present fellow can interact with the past fellows as well as mentors, not only national but also international, to gain experience and to enhance their clinical training or to enhance their way of treating patients in uro-oncology. This will help to them to interact with many mentors and fellows, and will have a global outreach. And more equally important is the mentor's appraisal as well as the fellow's appraisal, which will help us to pick up good institutes and pick up the inputs from mentors as well as the fellow to mutually improve the whole program as a whole. Before talking about Vattikuti, I want to just give you a brief background of how this word came. When I was interacting with my fellows, we have every 3-month interaction through Skype for the VCQI database. At that time, we call each other Fallopians. So then one of us told us that not all fellows are from Vattikuti. So why not Vattikutian? So that's where the term Vattikutian came. And I believe that it's important that we get a perspective from each and every fellow. So I had floated a Google form and asked them specific 3 questions, which are: what are the hits in your fellowship, what are the misses in your fellowship, and what are the pertinent few inputs you would like to give to improve this fellowship. I would like to share, but the hits were more or less the same, but there are very interesting misses which they mentioned. One is a structured program schedule. Next is a lack of structured program, a lack of exit assessment, competence assessment. One of them said there should be a common platform for fellows to connect with other mentors, especially international. One of them said that there should be continuation of mentorship support, and even somebody floated an idea of having a robotic society. Some of them mentioned about training module, quality checks and appraisals for the host centers on periodic basis. Some of them even mentioned of rigorous monitoring of fellows And some of them even mentioned as ex-fellows should be allowed for RSC, and there should be a registry for robotic surgery who are certified by Da Vinci. So before I can sum up my whole talk, my few 2 cents to the present Vattikutians is that, one, be ready to learn a lot, or make a comprehensive use of the resources at hand. But don't limit yourself to this only resource. Look at the resources beyond this. Open up your mind. Look at YouTubes. Look at, we have, Vattikuti has its own website where all the videos have been uploaded. You can go through those videos. We can make notes of them. We can understand how a particular step is being done. So watch videos. It is also important to imitate your mentors. The steps that the mentors do have come over a period of time. They are experienced steps which have been developed with a lot of pros and cons, with a lot of misses and hits. So imitate your mentors and then maintain basic data. Very, very important. So in the end, I would like to suggest these 4 points which I believe should be important from a fellow's point of view, which needs to be incorporated into the present fellowship. One is stronger curriculum, robust interaction between fellows, past fellows, mentors, internationally, nationally, robust assessment, and also appraisal. I wouldn't like to finish my talk without acknowledging my mentor and the co-mentors who have directly or indirectly taught me the skill of robotic surgery and also uro-oncology as a whole. And I talk on behalf of all the past fellows as well. And in particular, I'd like to thank Dr. Gautam, because he was the one who inspired me to shift my mode of presentation or my style of presentation to the one I'm doing right now. This is the first time I'm trying this style of presentation. So thank you, Dr. Gautam. I'd like to end my speech this way. Thank you.
The first thing that I did, which is really terribly wrong, was to fight with Intuitive. The first year, there were 110 robotic cases done worldwide, and I had done 97 of them. So I felt that they gave me a right to dictate to Intuitive how the training should be done. Wrong. My presentation was very simple. I suggested that they come and work 3 months with me, and I would teach them everything I knew. That would actually take 6 weeks, and then the other 6 weeks they would be teaching me what I should know, and we would take a limited number of trainees. Intuitive's approach was, how about a 2-day program? You come in and see how to use the robot, and then they'll start doing robotics, and you go to their place and help them do a case. They're really good surgeons. I mean, one of them is called Vipul Patel, and just go there and help him do the case. And I said, how do you propose that they're going to be competent with that? One of the simplest operations we do is a TURP or a cystoscopy, and this level of training wouldn't qualify us to even doing a cystoscopy things. And they said, well, we don't know what your problem is. We can get cardiac surgeons to come and train other cardiac surgeons in robotic surgery. So you're just a urologist. Why are you being such a stick in the mud? So I said, this is a very good idea. Why don't you get the cardiac surgeons to go and teach urology? So that was wrong. I mean, I should have had more of an in-depth discussion with Intuitive, and I did. And you realize that when you're dealing with a corporation, you're dealing at several different fiefdoms. There is the CEO who talks to you in a different way, and there is the head of sales and marketing who talks in a different way, and then there is the director of training who has a different agenda. And what I found over 20 years of dealing with Intuitive is that the people who really call the shots are the director of sales and marketing, not even the CEO or anyone else in the company. It's that person who's responsible for the viability of the company, and they call the shots, and they have one goal, and that is to sell as many robots as they can sell. So my response to it was that I will no longer take part in any Intuitive program. and I'll start training people on my own. And it turns out, and I didn't do this by intention, there were two criteria that you needed to become a Menon trainee in robotics. And you will laugh, but this is absolutely true. Number one, you had to be an MCH urologist from India. I mean, preferably an MCH trained urologist, but at least a urologist trained in India. And this is very simple because no American graduate ever wanted to come and train, and the Indians do. And the second thing is, I was going to go down the alphabetical order. So I was going to train everybody whose name started with an A. Ashutosh Tiwari, Akshay Bandari, Alok Srivastava, Ashok Hemal. And then after 4 or 5 years, I said, I'm being a little bit too restrictive. Let's go down and train somebody with a name that starts with a B or a C. And Akshay filled both criteria because his first name was start with an A and his second name started with a B. So he probably was the best trainee that I've had, by these selective criteria. Now, if your name started with a V, I would train you, but you would have to come to Henry Ford and come back again. And then I would send someone to your institution whose name started with an A, and you could become my indirect training, and that's how Vipul Patel got started. Tom Ollering, I helped train him, because again, you can see his last name started with an A. So I don't think this is a good way to start a robotics program. Thank you.
I'd like to talk today about is very different from a fellowship training program. It's about proctoring. And there are a lot of proctors here, and there are proctors here, and it's something which is completely different from a structured or even a fellowship program which has a definite finite time. Proctoring is basically something that you have to improvise and do on the fly. So let's actually go straight ahead. I'd like to, the only disclosure that I have is that I'm an intuitive proctor and I have a financial relationship with them. So I did get fed when I wrote this article. What is the goal of a proctorship? I think it's very simple. It's basically to produce a confident and safe robotic surgeon. And it is to take somebody from this state of conscious incompetence where the surgeon has realized that he doesn't know how to do good robotic surgery to a state where he reaches conscious competence, where he's able to do a safe and complete robotic surgery. And then the next progress, the step from conscious competence to unconscious competence actually occurs on its own with repetition and with the number of cases that a person is doing. The role of proctoring is also to assess the performance of a surgeon. And this assessment, based on a number of different criteria, can result in credentialing and making sure that a better patient care is offered to patients within his particular institution. But the most important is to ensure the safety of the patient. I think that is paramount. And this is what the proctor really has to do, to ensure the safety of the patient who's being operated right now, and also the safety of the patient who is going to be operated subsequently by the surgeon when the proctor is no longer there. And this is even more important considering the current environment where there does seem to be a situation where robotic surgery can potentially get a bad name because of some bad press or because of some lawsuits. And as a result of that, this is the additional responsibility that a proctor needs to take care of going in the future. So what is the situation right now? If you look at the situation right now, before I go any further, I would like to distinguish between these two terms, which is proctoring and preceptoring. Proctoring, what we commonly use now, is basically preceptoring. Preceptoring means scrubbing into a case, being a part of the case, taking the primary responsibility of the case, and doing a hands-on training or giving a hands-on training to the trainee surgeon. Proctoring, in the truest sense of the word, is basically just observation. The trainer surgeon does not intervene in the case. He or she just assesses what the trainee surgeon is doing and then gives a feedback either to the surgeon or to the hospital based on what are the terms of his contract. But for this particular talk and for, in general use, these two terms are used interchangeably. So what are the guidelines for proctoring that exist in literature? Fortunately or unfortunately, they are very few and very sparse. In fact, I did a research on this. I saw a few papers, I went through the literature, and one of the guidelines which I saw was the American Urological Association Standard Operating Procedure for Robotic Surgeries, which has been updated in 2018. And that is in fact based on an article that I had the honor to co-author at the beginning of my fellowship in 2009. And this article was written along with the stalwarts of robotic surgery for the Society of Urologic Robotic Surgeons, where we talked about training, credentialing, and proctoring. If a 2009 article is being used in 2018 to set guidelines of standard operating procedures by the AUA, it just goes to show how little work has been done in this particular field over the last 10 years. The problems that one faces as a proctor are many, and they are actually even more profound than the ones that Dr. Ahlawat mentioned about the problems faced by a mentor in a fellowship program. Firstly, one size does not fit all. You are going to get surgeons of a number of different shapes and sizes, a number of different years of experience, the number of cases that they have done, their skill level will all be completely different. So you have to modify your proctorship on the basis of these particular variations in the surgeons that you are training. Secondly, the quality of assistance is going to be hugely difficult. Some of the assistants that you will have in the institutions where you will go to train as a proctor will be absolute rock stars. They are going to be able to do anything and everything very easily with the laparoscope. However, in a lot of situations, the bedside surgeon is also learning the ropes of robotic surgery along with the console surgeon. And you may have a situation where you may be struggling between proctoring or training the bedside surgeon versus at the same time training the console surgeon. You may not have adequate tools. You may have a situation where you may be used to using 2 needle drivers to do the anastomosis, but in an institution you may have only 1 needle driver. Or a number of different equipments or hemolock clips or whatever you want may or may not be available at the place where you're going. Another very interesting aspect is what has the patient been told. Now, I have, not all the time, but sometimes I have landed up in an institution to proctor a robotic case where the trainee surgeon has actually told the patient that the entire case will be done by this person who's coming from Delhi. And when I question the surgeon concerned that why are you're going to be doing the case, I'm just here to help you out. The surgeon says that it is better or easier for me to retain the patient if I tell you that somebody is coming from outside to do this case who has already done quite a few of them. Now this puts you in a little bit of a fix. Are you going to do the entire case yourself, thereby defying or belying the very logic of doing a proctorship, because now the responsibility is yours? Or are you going to just continue to do the proctorship and let the trainee surgeon do the entire case, because that's what you're here for, while taking medical legal risk because the patient and the family think that you're the one who's doing the operation? So this can potentially land you into trouble and incur a medical legal risk, which fortunately I think none of us have faced till now, but we may have this situation coming up in the future. So what is the strategy and what is the solution that we can adopt to overcome some of these problems? Firstly, it is a good idea to be in touch with your trainee surgeon right at the beginning, even a couple of weeks before you actually go and travel to the institution to proctor. It's a good idea to be in touch with the trainee surgeon and discuss the case. Go over all the details of the case, the anticipated level of difficulty, the previous surgeries, comorbidities, what is expected from you in that particular situation. All those things need to be discussed before you land up to do a case. It's a very good idea, and I use it as a routine to share your own unedited video before you actually go to do a proctorship. So about 2 weeks or 10 days before the actual proctorship session, I send by WeTransfer a complete unedited video, and then the the trainee surgeon goes through it, and then we have a discussion on that, either over social media or on a video call, or even over dinner one day before we actually do the case together. So the steps are very clear, and we don't have to spend too much time while the actual surgery is being done. You should have your instrumentation in place. An entire list of instruments, sutures, equipment that you need should be with the trainee surgeon at least a week before you actually reach there. And that really helps in making the OR experience very, very smooth. We know that robotic surgery, like anything else, is basically a team effort. And the strength of the team is the strength of its weakest link. The only way to do a successful proctorship is to ensure that you train the entire team. Proctorship is not just about console surgery. Proctorship is about the entire robotic team. And in order to do that, it's almost essential, in my opinion, to always fly with your wingman. I always insist that the bedside surgeon whom we have worked with over the last many years is a part of the proctorship experience, and I never travel alone for a proctorship, always with the bedside surgeon. It makes the overall OR experience very, very smooth. You're not worried about the assistants. At the same time, you're also in a situation where the bedside assistant and the technical team there is also being trained simultaneously in bedside surgery while you are training the console surgeon at the console. Now, like Dr. Ahlawat mentioned, you will have a lot of different surgeons with different levels of experience and skill. So typically a proctorship should not be a one-off experience. If you go to proctor somebody, there should be at least 4 or 5 times you should be going there and proctoring them. As you keep on going there, their skills and their confidence will increase, and you can start letting them do many more difficult steps, or most of the difficult steps over a period of time. You may have been in a situation where the first time the surgeon is doing 50% of the case, the easier steps, but over a period of time the confidence will develop, and most of the procedures will be done completely by them. One of the techniques that I like to use, especially when the surgeons that I'm proctoring are new, is the mirroring technique. We basically decide this preoperatively, and we split the body into 2 halves, and everything in one half is done by me, and the trainee surgeon does on the other half. So the left side pelvic lymph node dissection I'm doing, the right side, and similarly for nerve sparing and all other aspects. This is usually required when you're going for the first couple of times. Later on, the surgeons just fly on their own and you just pitch in whenever you need to. Feedback is the most important step of proctoring. There's no point in spending time there unless you are able to give a proper feedback in terms of what the surgeon did right and what the surgeon did could have been better. And at the same time, the feedback is never a one-way street. As the surgeon is improving his technique, you are also improving your training technique. So the feedback always has to be two-way. You have to ask the surgeon about what experience he had with you and have an honest feedback about what you can do to improve the proctorship experience for the surgeon. So remain in touch, stay in touch even after surgery, and make sure that you travel this journey together where you become a better proctor and the trainee surgeon becomes a better surgeon. So please forgive my lame attempt at making an acronym out of the tips and tricks of doing proctorship. I am sure it's a very lame attempt, but I'll try it nevertheless. So P for preoperative interaction, R for review the case and unedited videos together, organize the equipment that you need, the sutures, everything. Carry your own bedside surgeon. You don't have to physically carry him, but there was a C there. I couldn't think of anything else. Train the entire team. Offer and expect honest feedback. And finally, remain in touch. Thank you very much.